try another computer. My one wasn't working.
Oh, good. It wasn't us. Thank you.
Yeah. I could see you, you just couldn't hear me.
Okay. Can you make this bigger, Fred?
Yeah, hold on. Let me see. Hey, how are you? There you go. I'm trying to enhance the video. There we go.
There we go.
Well, what have I been missing at your conference so far?
Well, we had Dr. Smith here this morning, he's a urologist here. And
Oh,
he's
cool.
actually still sitting here wishing to hear from you.
Okay, great.
Hello, Dr. Smith. He's also brought some of his fellow as well as a student. And we have about 33 survivors, and over a dozen of them are adults. Some as old as 50.
Okay.
Yes.
So how would you like to use the time? I did not prepare in particular, but I'm happy to answer the question.
Well, they want to hear about muscle transposition. There are a lot of families that haven't heard your lecture prior. So if you'd start with the basics about the muscle transposition, how it works, and what the purpose.
Sure. Well, I'm hearing a little bit of feedback.
Yeah, that's all.
What I started doing with muscle transplant was a procedure that was suggested by Dr. Gura, where you take one of 4 muscles from the thigh and you transpose or move those muscles up to the abdomen to try and get muscle function for the stomach. And this makes a lot of sense because with this condition you have no muscles in front of your spinal cord, just in the back. And so it's really, you can't have as good trunk control, and it's harder to raise the pressure inside your abdomen. And it's been reported that with Prune belly syndrome, especially in younger kids, are getting problems with more frequent respiratory tract infections because the cough isn't strong. It can be, you get more urinary retention because you can't bear down to completely empty the bladder, and more constipation. So there's a whole bunch of factors that could be improved by bringing muscles there. And so I've been doing this now, gosh, I don't remember for quite how long, but I think as of today I've been 23 kids and young adults. And the thing I've noticed the most, I think, and there may be some people in the audience who have had this operation done, the thing that gets reported to me is the most striking change is trunk control. Because it's easier to sometimes bend forward, bend backwards. You have a more straight posture with walking. It's really hard to assess how successful the operation is because I haven't had any patients say that they didn't notice any difference afterwards. But at least 2/3 of my patients are kids who are growing at the time that I do the operations, are getting stronger and bigger. And so when I see them back a year later or whatever, maybe they just grew stronger. It was irrespective of the operation that I did. One of the things that would be really nice to do is our studies like looking at the residual volumes in a bladder, for example, before you do the operation and afterwards, to see if the ability to increase your intra-abdominal pressure help to better empty the bladder. That's something that we actually be able to measure. So right now, all my positive feedback has been mostly patients saying they're controlled better, they're able to do things that they couldn't after the operation that they couldn't do beforehand. So that's kind of a brief overview of I think this operation has been, it seems to be doing pretty well. Does anyone have any questions about the procedure or some of my outcomes?
Yeah. Is it possible to do this in adults?
You might have to come closer to the computer so we can hear you.
Hi doctor, is it possible to do this procedure on adults? Maybe someone like a 30-35-year-old?
I think it is. I've done the operation on, I think, a couple people 16, someone in the mid-20s. So I can't think of a reason why I wouldn't young adult. Not sure. One of the things I'll be most interested in following is to see if there's a difference in the amount of back pain that develops over a real long term. I mean, a lot people without Prune syndrome develop like back pain or low back pain as they get older. And I've wondered, would this incidence be higher if you have muscles in front of your spine? So it's always bent backwards. Now the opposite thing could occur. There could be a lower incidence of back pain, but it seems that absent abundance of muscles, it might be an increased incidence of back pain. And I don't know if doing this operation would help reduce that or not, but probably be 20, 30 years after I've retired before we know answer that question.
Are you doing this procedure in sequence with abdominoplasty and urinary tract reconstruction, or are you doing this as a separate procedure? What is your protocol as far as how you do that particular surgery? Do you do it in a combination, or do you do it as a singular surgery? And what age limits do you do up to? And
that's a good question. I like to wait till the kids are about 18 months old, because the lower extremity is growing so fast in the first 18 months, some of them will get a longer muscle, reach higher up, if I wait that long. And most of the operations I do are in combination with something else. I'm a huge fan of reducing operations. So I would be happy to wait until one just wants to do orchidopexy or a ureteral implant or a nephrectomy or some other operation. I think it's good to hold off and combine them.
okay, and when you do that, do you also do the reconstruction as well? I mean, like the total urinary tract reconstruction as far as bladder reduction, the ureter reimplantation, that type of thing, or is that too much for you in one surgery? How long does this particular surgery normally take you?
The operation takes about, if nothing else is being done, it takes about 3.5 hours, 4 hours. But I'm not a urologist, so I don't do ureteral reimplants or bladder reduction. So the urologist in Dallas combine the operation with me. So I will open up, and the urologist will do orchidopexy, whatever they're doing. And then when they're finished, I would do the abdominoplasty and then do the muscle transposition. So I do both those at the same time.
Okay, and after the muscle transposition is done, does that muscle grow, and what exactly does it attach to?
So it stays attached to the upper pelvis, and then I cut it right above the kneecap, and that part that I cut, it's flipped upside down and runs through its funnel to the stomach. And I sew it to the fascia strength layer of the stomach, somewhere between the belly button and just, I get as high as I can up. I sew down so it attaches to that fascia there. And the easiest way to see if it's functioning is to have a child or adult lie on the floor and start to do a sit-up. And if you put your hand in the abdomen, you can feel it flex. But I've also gone into the operating room if one of my patients is having a different posture, and I've used what's called a muscle stimulator while they're asleep to see if it flexes. And so those are the two ways I've been able to ascertain the muscle seems to be working. I would guess that it would probably grow the more you use it. It's like any muscle. If you use it a lot, it will get bigger. There's one particular teenager I did. It was in his late teens, maybe he was 20. who had really big muscles everywhere. And when I brought those two thigh muscles up to his stomach, it really ripped. But he was overseas and I've not seen it back. I've just heard by email that it's working well, but I haven't had the opportunity to examine him. But when he left, he had really huge abdominal muscles. So it'd be really interesting to see what happens over time, see if they get smaller or if he's using them a lot, if they get larger. I'd say the biggest disappointment, I want to say disappointment, but shortcoming is this muscle is not wide. So if you use a lot of your abdominal musculature, you can have bulging outside these muscles. So some patients have a muscle off to the side than others, and that kind of turns longer term kind of result.